Welcome to NCPDP, Unscripted, the podcast where healthcare meets real talk. Each episode, we will dive into unscripted conversations with industry leaders, changemakers, and innovators, discussing the challenges, breakthroughs, and behind-the-scenes stories you won't hear anywhere else. Whether you're on your morning commute or taking a break between meetings, settle in because it's time to get unscripted.
Well, Steve, welcome to the NCPDP Unscripted podcast. Really excited for you to be joining me today.
Excited to be here. Thank you for having me.
Great. Well, I'm sure some of our members know you from some of the work that you did a couple years ago with NCPDP and the value-based care work, but I think a lot of our listeners probably don't know who you are. So if you would just take a minute, tell us who you are, where you're working, and what you're working on.
Sure. I'm Steve Chen, Associate Dean for Clinical Affairs at the University of Southern California Mann School of Pharmacy. I say that because when I say USC, everyone thinks South Carolina.
Right.
But to be clear, I'm in Southern California.
Yeah.
I've been there for 25 years, and before that, worked for the VA. Have been a primary care pharmacist all my life, so really focused on the clinical care space. Worked at Cedars-Sinai a little bit, and then worked for Skid Row, the homeless population, for about 10 years. So I've seen a little bit of everything during that time period.
Interesting. That's great. So tell me a little bit about what you're doing at USC around clinical services and pharmacy.
Yeah, so my responsibility for the school is to manage the clinical relationships we have with all of our partners, whether it's for teaching or some kind of partnership that supports our faculty. But I think more importantly, we're trying to expand the opportunities for our students today, right? We know healthcare evolves and all the time, but it's evolving faster than ever today. We want to make sure our students have viable, thriving opportunities once they get out of school. So my job is to take a look at where is the industry going, where do pharmacists align best with the critical needs in healthcare, how do we create a system of providing that care, that opportunity for our students where they can not only deliver it but also get paid for it in the end.
Yeah, that's a big thing, and I love that because it's really aligning with what we're doing. We just came out with a new 3-year strategic plan, and what we're starting to recognize is just this expanding role of the pharmacist and how we can support that. I know you're here in Spokane at the work group meetings to facilitate a health plan executive roundtable, which we're really excited about.
Me too.
And I think part of our goal is to figure out how do we get more health plans to recognize that they can be using pharmacists. So we'd love for you to just chat a little bit about that and what you're seeing in California and what you're doing down there.
Yeah, $1 million question. Well, I'm thrilled to be here for so many reasons, among it being, as you know, Washington is the first state in the nation to actually have provider status for pharmacists and make these payment streams available for pharmacists providing clinical services. So I think what we're seeing, and you know this too, is I hate to put it this way, but I graduated 35 years ago.
Yeah.
When I graduated, I was told any year now, pharmacists will get provider status.
Right.
Here we are 35 years later, not quite there yet.
Yeah.
But what we're seeing is state by state, we're getting those wins. We're getting states to recognize pharmacists as providers, probably more importantly, to provide payment mechanisms and legislation to support payment for pharmacists.
Yeah.
One of the mistakes I can't say it's a mistake, but when we had our provider status bill approved in California in 2013, we didn't have payment tied to it. So it's like being on the team, but you may never get to play, right?
Right.
So I think what Washington did right is they got it all in one shot. Status, payment, everything else.
Yeah.
So I'm not shy to say that we're here to learn from other states that have gotten it done right.
Yeah.
And I'm hoping, my hope is that as other states learn from other states, implement these not just provider status but payment parity legislation, that we get to the point where so many states are doing it that the feds have to agree that this just makes sense. It has to become federal.
Yeah, it does seem to be, and I think that's what also makes it hard though for pharmacists because it really is state by state, right? It's every state you go into is a little bit different on what pharmacists can do, what they can prescribe, clinical services. Just curious your thoughts there, and is there anything we can be doing to kind of...
Well, as I've shared with many of my colleagues, I think we're kind of stuck in that state by state mode at the moment just because in order to take something that's been approved in a given state and then move it, scale it up to something that actually operates and works, that takes a lot of work. And what works in one state, unfortunately, isn't cookie cutter or cut and paste work for another state. Right? Everyone's a little bit different.
Yeah.
So that's the challenge part of it. I do think, though, that the more we talk between states about what we're doing, hopefully get to the point where we start to standardize operations, procedures, approaches, so that as we get more states engaged, and ultimately federal engagement into this work, we have sort of one process that just makes the most sense for everybody.
Yeah, that would be nice. So you, as I mentioned in the beginning, you did some work with us when we were looking at value-based care agreements and some of our standards. I'd love for you to just talk a little bit about that work. I think we are at a point, right, where people are recognizing that, it is worth to pull pharmacists into this. But I think what we kind of lack is being able to share data and things like that. So I would love to get your kind of thought on, we say interoperability, right? But really it's about pharmacists being able to access the data they need to do these clinical services. So what are you seeing today, and, what are you teaching your students, I guess?
Okay, so I'll talk about some more failures than successes, put it that way.
No.
And again, why I'm excited to be here is because we have so many people in different places that can help to answer some of the challenges that we face. So you said it very well. In order to facilitate a value-based payment, you need data.
Yeah.
You need fast access to data. You need it on many fronts. Let's give an example. When you're in an integrated health system, it's pretty easy to get the data you need to provide the care, to provide the documentation, to get the billing done.
Yeah.
So any states where provider status and payment applies to pharmacists in integrated health settings, I don't see a problem there.
Yeah.
In fact, here in Washington, I recall hearing that when the provider status and payment bill came into place, in really a relatively short amount of time, it quadrupled the number of pharmacists that were practicing in the integrated health system. So again, that's not a surprise.
Yeah.
I think the challenge part of it is in the community pharmacy side, where you're kind of a data island in many cases in regards to accessing health information. I mean, if you think about the complexity of some of these patients that are being sent to pharmacies for longitudinal care, chronic disease care, to make good decisions that physicians and other health professionals will trust, are sound, reliable, et cetera, you need timely access to that clinical information. And so that's always been a challenge. As we get more health information exchanges in place, I think that will resolve it. But at least for now, in our neck of the woods, I hate to say, it's very much a system by system kind of arrangement. An FQHC agrees to share data with a pharmacy. That's ideal. That works very well. But that's just the provider part of it, right? Now we're talking about the payment part of it. How do you facilitate a value-based payment where you have metrics that you need to meet that may not exactly be HEDIS or other NQF type metrics in order to get paid? I have not seen a process that works very efficiently within pharmacy. I'm counting on NCPDP to come up with an answer for us, to be honest.
Yeah, we could work on it. I mean, I used to do consulting work, and I remember hearing people say, we're using pharmacists to close gaps in care, we're doing this or that. And it would be like, how are you getting the information? Like, oh, we're faxing a list over. Or, okay, how are you paying the pharmacy? Oh, we're writing them a manual check. And, it's like, oh, we need to solve for this.
Yes.
Yeah, so definitely something.
I'm sorry to interrupt you. I think where we can align incentives with other providers, it works really well. The challenge becomes, how do you differentiate the contribution of the pharmacist versus other elements of the system, right? Now, we tease that out when we do our rigorous analyses of our impact or impacts of our other systems. We do things like propensity scoring and things to look back at a cohort of patients that look just like the patients that were intervened on, the only difference being whether a pharmacist was involved or not. So from a evaluation perspective, we can tease that out pretty well. But prospectively, from a payment perspective, it's pretty hard.
And you touched on quality, and I think that's really important too. And I know there's been so many studies out there how pharmacists can impact quality payments. And I heard a story the other day about a provider that just says, hey, I've got my patients that are attributed to me, and I just blast them out to all the community pharmacies and say, hey, if one of these patients come in, grab their blood pressure, or just check their their A1C levels, and they're actually paying them. And I feel like there's just pockets of this stuff going on, but how do we get that information out to say, hey, let's make this more sustainable, and also be able to have others do it. So
I love that example, by the way. It sounds like the ACO partnership we have right now, where the worst part, let me back up a little bit. As you know, CMS has many value-based payment models, and what's nice is that someone that I worked with once who used to be at CMS, Dennis Wagner, Director of Quality and Innovation, when he got there, I don't know if he ever shared this story with this group, but he was told by his higher-ups that don't listen to pharmacy. They just want to get paid more. And he came from HRSA, where he worked with me and a number of other people, and he understood what pharmacists can bring. So instead of just kind of outright advocating and saying pharmacists need to be paid, he created many of these value-based payment models where if you don't include a pharmacist, you're not going to perform well, right?
Yeah.
So I think there's a lot of those, such as the ACO model.
Yeah.
The interesting about the thing about the ACO model is sometimes the physicians don't even know that patients are attributed to them.
Right.
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 But to your
Yeah.
point, once they know,
Yeah.
they do look for help because, come on, they already have no time to do what they need to do in a given day.
Yeah,
So
exactly.
that's how we're engaging in programs like that.
Yeah.
We have pharmacy teams that are helping identifying those patients that are falling through the cracks, so to speak,
Yeah.
enrolling them into some kind of follow-up program to ensure that they reach the treatment goal.
That's great. That's so great. And I think, with CMMI, I know there's lots of changes happening over there at CMMI, the Centers for Medicare and Medicaid Innovation.
Right.
I know a couple years ago, I remember hearing they hired a pharmacist, and I kept waiting and waiting for some kind of model to come out. But now I was actually chatting with quite a few people that are saying, we're actually considering looking at something like that, which I think is really important. And
Yes.
it sounds like there's some models out there, but I think as we continue to move things forward as an industry, there maybe hopefully there's some opportunities for that.
Absolutely.
So, yeah. So I know we're getting to the end of our time together, but would love to just understand. You said you've been doing this for 25 years, and I know I've been doing it for 25 years, and I feel like there's a lot of hope. Like I feel like the time is right, and
Yeah.
I'm curious what if you're feeling that way, and
Yeah.
what you see in the next couple years.
Let's be very frank here. The evidence of the impact of pharmacists in helping to manage patients with uncontrolled chronic disease, it's overwhelming.
Yeah.
And much of it is government-sponsored research. So the proof is there.
Yeah.
I think the challenge part of what we're talking about here is the implementation. And then we haven't even talked about it. What about AI coming
Yeah.
in? Does that
Yeah.
help? Does that
Yeah.
hinder? I think it helps. I think there's the potential is fairly limitless, but I think it's going to enable pharmacists to more efficiently and more safely impact more patients. So I'm optimistic. I think that as we develop and integrate AI tools and platforms into pharmacy practice, I think it makes everything better for everybody. And pharmacists will find that, hey, I get to do the things that I finally trained to do in my practice.
Exactly.
Right?
Yeah, that's great. Well, thank you again so much for your time, and I think we're definitely going to have some great learnings out of this roundtable we're doing, and excited to hear what you're doing in California. And I love that you're kind of coming up here to learn too
I
from
am here
another
to learn.
state.
Absolutely.
Yeah,
Yeah,
if we
thank
can.
you.
Looking forward to that. So thanks again,
Me as
Steve,
well.
for joining me.
Thanks for having me. Appreciate it. Thank you.
That's a wrap on this episode of NCPDP Unscripted. Thanks for joining us as we explore the voices and ideas driving innovation in healthcare. If you'd like to be a guest on the show or have topic ideas you'd love to hear us cover, we want to hear from you. Until next time, stay curious, stay connected, and stay unscripted. Our podcast is proudly sponsored by Marks Productions.